Welcome. In this section we will go through the humerus. We start with the proximal structures, then proceed along the shaft to the distal end. The first landmark is the column anatomicum humeri. This is a shallow, circular groove that separates the cartilage-covered head from the two tubercles. Here the surface covered with hyaline cartilage ends, and from this point begin the attachment zones for the shoulder muscles. Next is the corpus humeri, the shaft of the bone. In its upper part it is more cylindrical, while further down it takes on a rounded triangular cross-section. Along this region run the ridges and rough surfaces that provide muscle attachment and distribute the pulling forces during movements of the arm. Continuing downward we reach the condylus humeri, the distal articular block. It carries the articular surfaces that belong to the elbow joint. Later we will highlight the capitulum and the trochlea, as well as the surrounding fossae. On the proximal end, laterally, rises the tuberculum majus. It is a broad, polygonal area for muscle attachment, where several of the rotator cuff muscles anchor. From here runs its own crest downward, leading toward the anterior surface of the upper arm. On the anterior surface, more medially, lies the tuberculum minus. It is smaller than the greater tubercle, but its muscle attachment is essential for internal rotation of the shoulder. The connection between the two tubercles is shown by the longitudinal groove. Finally, let's look at the head of the humerus, the caput humeri. The head faces medially, upward, and slightly backward. Its spherical surface fits precisely into the glenoid cavity of the scapula, allowing a wide range of motion in the shoulder joint. Now we come to the longitudinal borders and surfaces. The anterior edge is the margo anterior humeri. From here the proximal crests run downward, and this border gives the anterior contour of the arm. The anterolateral surface, the facies anterolateralis humeri, approaches the attachment zone of the deltoid muscle. That is why this surface is slightly convex and built of stronger bone. Next to it is the anteromedial surface, the facies anteromedialis humeri. Here the bone is smoother, and the course of the proximal crests is clearly visible. The lateral border, the margo lateralis humeri, defines the outer contour of the arm. Toward the distal end it transmits the tension of muscle origins and ligaments toward the elbow. The distal outer projection is the epicondylus lateralis humeri. This is the main origin for the forearm extensor muscles. Just above it, running upward, is the crista supracondylaris lateralis, a sharp ridge that can easily be followed by palpation. The inner longitudinal border is the margo medialis humeri. At its distal end lies the larger projection, the epicondylus medialis humeri. This serves as the principal origin for the flexor muscles, and therefore forms a more prominent elevation. From here the crista supracondylaris medialis runs upward, forming a ridge on the inner side of the arm and guiding the eye from the elbow back toward the trunk. The large posterior surface is called the facies posterior humeri. On this surface appears the characteristic groove marking the course of the nervus radialis. Now let's move on to the distal articular surfaces. Laterally lies the capitulum humeri, a rounded surface that slopes slightly forward. It articulates with the head of the radius and allows rolling movement on the outer side of the elbow. The other half of the distal articular block is the trochlea humeri. This is an elongated, spool-shaped surface with an axis slanting slightly medially. It articulates with the notch of the ulna and guides flexion and extension of the elbow. In front of the trochlea, medially, there is a shallow depression, the fossa coronoidea. Into this fits the coronoid process of the ulna during elbow flexion, preventing bony collision at the end of the movement. Anteriorly, laterally above the capitulum, we find the fossa radialis. During flexion the head of the radius sits here, ensuring smooth movement. On the posterior side, at the center of the distal end, is the deep fossa olecrani. During extension, the olecranon of the ulna fits precisely into this hollow, stabilizing the end position of the movement. On the distal medial side there is a deep groove behind and below the epicondylus medialis, the sulcus nervi ulnaris. The ulnar nerve passes here, which explains the characteristic electric shock sensation when the elbow is struck. On the posterior surface, running from medial to lateral in a spiral direction, is the sulcus nervi radialis. In this groove course the radial nerve and its accompanying vessels, producing the characteristic groove of the posterior arm. On the outer middle third of the shaft there is a broad rough surface, the tuberositus deltoidea. Here attaches the deltoid muscle, the main mover in raising and swinging the arm forward and backward. At the junction of the proximal end and the shaft lies the column chirurgicum humeri, the surgical neck. This is a mechanically weaker zone, and fractures of the upper limb often occur here when falling on the arm. From the greater tubercle descends the crista tuberculi majoris. In parallel, on the medial side, runs the crista tuberculi minoris. Between the two crests on the anterior surface lies the sulcus intertubercularis. The tendon of the long head of the biceps passes through this groove, covered by a strong ligamentous roof forming a canal. To summarize, it is worth constructing a mental map. Proximally, the head, the anatomical neck, and the two tubercles form the shoulder pole. On the shaft, the two crests, the deltoid tuberosity, and posteriorly the radial groove are the most important landmarks. The condylus with its two parts, the capitulum and the trochlea, together with the epicondyles and the three fossae, define the topography of the elbow. This gives the complete picture of the humerus structures on the model. Now that we have reviewed the humerus and its important bony landmarks, it is worth mentioning a common condition directly related to these attachment sites, epicondylitis humeri, the collective name for tennis elbow and golfer's elbow. The essence of epicondylitis humeri is that the tendinous origin of the forearm muscles at the outer or inner epicondyle undergoes chronic overuse. Repetitive movements lead to microtrauma and degeneration in the tendon. Importantly, this is not a classical, acute inflammation but rather a tendinopathy. Symptoms therefore develop slowly and insidiously, and they are load-dependent. Two main forms are distinguished. Lateral epicondylitis, better known as tennis elbow, involves the origin of the extensor muscle group at the lateral epicondyle. The short wrist extensors are often the main source of pain. The other is medial epicondylitis, or golfer's elbow, where the flexors and the pronator teres arise from the medial epicondyle. The two forms behave like mirror images. The lateral one causes pain on the outer side, the medial one on the inner side. The symptoms are characteristic. There is tenderness on palpation over the affected epicondyle. Pain appears on exertion and with specific movements, often radiating into the forearm. In everyday life this is noticed when opening a bottle, turning a key, scrolling with a mouse, or hammering. A sudden stabbing pain shoots in. Grip strength decreases, and patients may drop objects because the pain prevents them from holding firmly. Diagnosis is primarily clinical. In Cousin's test, the patient extends the wrist against resistance with the elbow extended and forearm pronated. In lateral epicondylitis, this provokes immediate pain. Mill's test is passive stretching. With the elbow extended and forearm pronated, the wrist and fingers are maximally flexed. This also provokes lateral pain. The flexion, pronation test points to the medial form. The patient flexes the wrist and pronates the forearm against resistance, causing pain on the medial side. Imaging is rarely required, mainly if the presentation is atypical or symptoms persist. First-line treatment is conservative. Rest and activity modification, a short course of non-steroidal anti-inflammatory drugs, and targeted physiotherapy are key. Stretching and gradual strengthening, especially eccentric exercises, are emphasized. Correction of workplace ergonomics and sports technique is often decisive. If symptoms persist, injection therapy may be considered, short-acting corticosteroids or platelet-rich plasma. Surgery is rarely indicated, only if conservative measures over several months bring no improvement. The key point: this is an overuse-induced tendon origin injury, with characteristic provoking maneuvers and well-targeted physical tests. With consistent load reduction and guided exercise therapy, most cases heal well.